My name's Helen Goldsmith and I'm the Research Development Manager. Sorry, it is very loud in here. Yeah, Research Development Manager with the Sydney Children's Hospital Network. Welcome to Randwick Research Series, and this session is on future fertility. So I'm just going to give you a little bit of background on my role here because it's a relatively new role. I was just chatting that I've probably been in the role just over 2 months now. And as you're all aware of kids research across the network, you've got our Director of Research and we've got our Associate Director of Research Operations. Within our team, we've also got our Research Office. So we've got our Ethics and Governance. We've got our Finance Officers. We've got someone that looks after the facilities within research. We've also then got the clinical research centres that lie within that, and also kids advanced therapeutics and early phase studies as well. So we sort of all come together as part of this kids research operations team across the network between Westmead and Randwick. So you'll see different faces, interactions, and hopefully opportunities to mingle and connect. So, as you're aware with research, there are many different facets, and I think this Randwick Research series and seminar is pretty much a very good depiction of that. So, we've got anything from, we've got a REDCap system for those that are entering research data. We've got a clinical trials management system. We've got the kids research website. We have grants. We have data that we try and pull. We have labs that we do our studies in. We've got hospitals. We've also got different departments, different clinicians. We have policies and procedures, governance, and, for those that don't know, we've got a national clinical trials framework that's coming as part of our hospital accreditation as well. So we're embedding research into our clinical space. So there's lots happening. And within that, we've got medical research institutes, so MRIs. We've got universities that want to interact with us. We've got a Sphere. We have Sydney Health Partners. We have OHMR, NHMRC. I hope some of these acronyms are familiar with most people here. And, the research precincts as well, and particularly coming back to Randwick and also the Westmead research precincts. So how do we navigate that? How do we bring them all together? My background is I'm a registered nurse, and I started clinical trials back 20 odd years ago. So I started in oncology and then went into cardiology. Then I moved into trauma, anaesthetics, ED, and have played in lots of various spaces with pharmaceutical companies and also investigator-initiated studies. So working with clinicians to maybe develop a research project they're thinking of, data pools, quality improvement projects. I was doing a lot of studies for everyone else. I managed to do my PhD along the way, so I could actually do my own research and get that real good understanding of what research entails. And just recently have graduated with a Masters of Health Leadership Management. So collectively, I feel that I've sort of been placed into a position to be able to bring everything together, have a really good understanding of where you guys are, what we have around us, and how do we work together successfully, effectively, and sustainably. So bringing my 20 years of research experience, my position is really to promote, encourage, embed, and support research across the network. So feel free to reach out as you need to. Again, my name is Helen Goldsmith. You'll see my emails and on the health emails, and certainly you can reach out to Sam if you need to get in contact with me. So if there's any sort of questions helping navigate where do I find this information, anything to do with research, grants as well, please feel free and easy enough to reach out to me. Having said all that, I'm very excited to introduce 2 wonderful speakers today. But the very first one is Dr Rebecca Deans, who's going to talk about Australia's first uterine transplant. She's a senior lecturer with UNSW. She is a paediatric and adolescent gynaecologist and a fertility specialist with Royal Hospital for Women. Thank you.
Thank you very much. Excellent. You've got my talk, which was a bit of a stress getting that uploaded. Thank you very much for inviting me along to, I think, what is the 3rd or 4th of this series. So it's very exciting and a great initiative. So I'm going to talk about today uterus transplant, a treatment option for absolute uterine fertility. So what is absolute uterine factor infertility, and what is the prevalence. So AUFI is a condition where women can't get pregnant because either they don't have a uterus, and the congenital form is MRKH, or Mayer-Rokitansky-Kusterhauser syndrome, which affects about 1 in 4.5 to 5,000 female live births. Those women have fully functioning ovaries, but have complete uterine agenesis, and I've been treating those women for more than 10 years in my clinic at the Royal Hospital of Women. Often they present with primary amenorrhea, so they go through secondary sexual characteristics, puberty normally because they have ovaries, and then there's just no period, and you investigate them and find an absent uterus. Alternatively, it can occur in an acquired way through hysterectomy, and that might be through cervix cancer. So early stage cervix cancers are treated with either a trachelectomy or a hysterectomy, or it might be a hysterectomy due to postpartum hemorrhage, for instance, where women need to have a hysterectomy as a life-saving procedure. We don't really have an idea of the prevalence. When you look at reproductive age women who do not have a uterus, it sits at somewhere between 3 and 6%, but of course not all of those women are actually wanting to conceive, so we don't really know what the prevalence is of this condition. But certainly there's been a lot of interest in my clinical years. So I need to paint the story of how this all began. So it actually began in Adelaide in the late 90s, where this guy on the left, Mats Brandstrom, who was a gynae oncology fellow at Royal Adelaide, I think, Hospital, with who we have in the audience. He met Angela, who had stage 1B cervix cancer, and was booked for a radical hysterectomy. And at that time, she said to him, why can't you do a uterus transplant? And he's told this story many, many times around the world, and he always references Adelaide because it's very important, because it gave him that first idea. He went away, he did a literature search, he realised that could this be possible or not? I think there had been some failed attempts. And then he completed his fellowship and went back to Sweden. And where he lived was in Gothenburg in Sweden. And from that moment, from 1999, he started his animal research studies. And he studied the uterus transplant in the mouse, rat, sheep, pig, and then eventually non-human primates prior to actually implementing it through in the human experimentation. So he really followed an ideal model for surgical studies, which often is not actually undertaken. And that's when I first met him, when he had initially had ethics approval in 2010. And I went to see him in Gothenburg because I'd been working with women with MRKH, and they always asked about fertility and they always asked about uterus transplant. And actually one of my patients said, I hear they can do that now. And of course, all that was announced was that someone had had ethics approval in Sweden, and it was in the lay press, and that's how she found out about it, and that's how I linked in with Mats Brandstrom. So there had been 2 early attempts, as I mentioned earlier, one in 2001 and one in 2011, and both of them had failed, largely because of the vascular supply to the uterus. So the uterus is quite a unique organ. It's not a static organ like a kidney or a liver. It sits free in the pelvis and is quite prone to movement, which is not great for the vessels. The other very unique thing is the vasculature. So if you look closely at the uterus anatomically, and when you're doing a hysterectomy, all the veins and the arteries are sort of like spirals going down the side because it has to stretch and grow quite rapidly in pregnancy. And as a result of that increased growth, the vessels can then elongate. And that's quite an important function because the uterus has to supply the placenta and give a lot of blood supply to the placenta, and hasn't got a lot of time to grow. So it's got difficult anatomy to deal with. And I think the exploration of those factors and the improvement in the surgical technique has led ultimately to the success. So I'll tell you about the first Swedish study, which was on 9 human cases from the first trial. The recipients were between 27 and 38 years of age. They had quite a low BMI. 8 of them had the congenital absent uterus. 1 had cervix cancer. They all had IVF prior to their surgery, and had a minimum of 5 embryos frozen. They've now changed their protocol to 10. And both the donor and recipient underwent extensive preclinical evaluation as well as psychological assessment. I feel like that is echoing. Is that going to be better? And first I'll tell you about the donor surgery, which is the more difficult surgery of the two. So this is Professor Brandstrom and above Pernilla Darm-Karma, who's another very involved gynae oncologist who's done all of their studies, all their surgical cases as well. So it's very much a team effort. The donor surgery took between 10.5 to 13 hours. They had bilateral dissection of the vascular pedicles, and that includes those uterine vessels all the way out to the iliac vessels, and really taking out all of those vessels extensively gives that opportunity to have a good anastomosis, so a good connection between the blood vessels, and then ultimately success of the organ. And so they basically do 2 to 3 separate anastomoses of arteries and veins. And so often you get 2 anastomoses, one on either side near the vaginal vessels or the uterine arteries. And then if you're able to, you can sometimes use the ovarian vessels as well. And the ovarian vessels are much bigger gauge vessels, so they're much easier. But obviously if you do that, you have to remove the ovary, so you don't want to put the donor, giving their live donors, into early menopause. So they were really reliant quite heavily on those deep pelvic veins and arteries. The hospital stay was 6 days. There were no ICU admissions. The second donor had a uterovaginal fistula, which was completely repaired, and she's well post-operatively. And as I mentioned earlier, when we do a hysterectomy, usually, can you see my cursor there? No. I don't know if I have a pointer, but basically you take a much more extensive dissection, and you include the fallopian tubes as well, so that all gets removed from the donor. And the recipient surgery is easier, it's faster, 4 to 6 hours. You have to do surgical preparation, so obviously they're both done by laparotomy, a midline laparotomy. You need to prepare the vessels out to the iliac so that we can perform the end-to-side anastomosis, which you can see on either side there. And you need to separate out the vaginal vault from the bladder and rectum to connect the vagina to the vagina. So not only do you just take the hysterectomy with just the cervix, you need to take an upper cuff of the vagina, so that shortens the vagina as well. Their hospital stay was something between 4 and 9 days, and they obviously need to have immunosuppression. So the way that immunosuppression was managed, and it's evolved through the years, because this was a little while ago, but they had induction on the day of their surgery with 2 perioperative doses of globulin and methylprednisone. From the day of surgery, they had tacrolimus and MMF, and this was discontinued after 8 months if they had no more than 1 rejection episode. If there were several rejection episodes, they replaced that with azathioprine, and this was the original protocol. The way that we monitor for rejection is through cervix biopsies, because there's no blood test for the function of the organ. So you do that by putting a speculum in, as you would like a pap smear, and you take a biopsy, and it's a histological diagnosis looking for, inflammation and ischemic changes. In their protocol for cervix biopsies, 5 of the 7 women had some mild subclinical rejection episodes during that first year, but all were reversed with a brief course of increased corticosteroids. So none of them had any removal of the uterus due to an acute rejection. And then they were very lucky to report their first live birth, who was a 28-year-old with MRKH. And she actually was not the first uterine transplant surgery, but she was the first live birth. So after they had undergone the immunosuppression protocol and were satisfied there were no rejections, you start doing embryo transfers. And of course, not every embryo transfer takes. So actually, it wasn't the first transplant that led to the first live birth. She had a single kidney and developed preeclampsia, so he needed to have an earlier caesarean section. They're all delivered by caesarean because we worry about the vaginal anastomosis, and also they don't have. Well, the other reason is we want to be able to plan their caesarean, not have it in an emergency fashion if they trial labour, and also they don't, because we don't connect the nerve supply, they don't have the sensation of pain of labour. So interestingly, they wouldn't feel the pain of labour, and so that may impact being able to actually deliver and push, etc. So they didn't want to test that out, so they all had Caesars. But this case actually came a bit earlier, and in their initial trial they actually planned to do their caesareans at 34 weeks, just to make sure that the babies were, they didn't have any issues with placentation and fetal death in utero. So the second case 2, which is the first live birth, as I mentioned earlier, it was pregnant on her first embryo transfer. It was uneventful till about 31 and a half weeks. Then she developed preeclampsia, but had a baby born via caesarean section at 31 weeks, and good size for 31 weeks and good APGARs. And now the baby's, doing very well and going to school. The possible causes of the preeclampsia could be the single kidney, could be MRKH. We don't know much about MRKH pregnancies because we've only had a few. Obviously, her donor was 61 years of age, and there may be an issue with having that older uterus. And it could be just IVF, where there is a probable slight increased risk of preeclampsia as well. And so the outcomes of that initial trial, at 6 months, 7 of the 9 uteri were kept in situ. 2 had to be removed, 1 because of infection, the other one because of a vascular complication. So really, once you've got beyond the first month, and this has been shown in other studies around the world, then there haven't been any issues with ongoing function of the uterus. You tend to have your problems in that first month that requires removal. It's not to say you can't have rejection episodes, but there's been no uteri removed because of rejection. That just requires increased medication, and they've tended to be able to then have an embryo transfer at a later time. They waited 12 months to do their embryo transfers because they were just being very cautious, and as of 2017 there had been 8 babies born from the Swedish trial. They have a higher incidence of preeclampsia, had cholestasis in 1 woman, and the mothers generally were in good health after their procedures. And the uterus is removed after a maximum of 2 pregnancies, or they've completed their family. And we've got the same thing within our ethics protocol, which I will go through. This is just a brief slide because I'm aware of the time, to show that there have now been many, many more teams around the world performing transplants who have also reported live births, and many of them, most of them, have been trained actually by the Swedish team. So either trained in Sweden or by the Swedish team going over and performing the surgeries with those teams. And on the left shows all the places where transplants have been performed, and on the right those planning to start in the next little while. The graph on the right is to indicate that this has really taken off exponentially as compared to other ephemeral VCA transplants, so vascular composite allograft transplants, which are not life-saving, things like face, hand, penile transplants, of which there hasn't been nearly the uptake, and it's largely because you only have a very short amount of time on immunosuppression, and that's your main morbidity with any transplant. So if you're minimising the amount of immunosuppression, then you don't have the ongoing issues associated with that, and that's what people tend to remove their VCAs for, because they don't like the side effects of the immunosuppression. And just showing multiple cases published around the world by deceased and live donors. So although the first trial in Sweden, it was live donors only, other countries around the world have had live births, such as Brazil, which is the first live birth, and Cleveland, using the deceased donor model. And there's also been minimally invasive uterus transplants performed around the world, done by robotic surgery. The Swedish team have actually moved to doing their procedures largely robotically. and also conventional laparoscopy, although those done by conventional laparoscopy required the removal of the ovaries to have an anastomosis with those larger gauge vessels, which would be something that would be very difficult to get through an ethics committee in Australia, and not something you'd do willingly for someone who was premenopausal. So the complications, and there certainly are many, mainly in the donor, and it tends to be around the ureters and the bladders, because that deep dissection down to the pelvis is the problem, and you see that with radical hysterectomies that we perform for cervix cancers, which take the paracervical tissue, which is similar, although this is even wider than that done at a radical hysterectomy, and we see the same sorts of issues around like vaginal cuff dehiscence. We see fistulae and ureteric lacerations, etc. For the recipient, there can be prolapse, vascular thrombosis requiring removal of the graft, UTIs, hematomas, etc. And so the ethical consideration, which I've alluded to, it's non-vital organ. Obviously, you need informed consent. It's costly, probably in the order of between 100 to 100,000 Australian dollars per transplant when you include every component of it, including time off work, etc. There are perioperative complications, particularly for the donor, and then there's immunosuppression risks, which I've discussed earlier. So now moving on to our project, which is a collaboration with the Swedish team and a collaboration multi-site study within New South Wales. The ethics was approved in 2020, but unfortunately we weren't able to start because of COVID closures to surgical studies. The study is across Westmead Prince of Wales Hospital and the Royal Hospital for Women as the primary site for recruitment and surgery. And the data storage and the research will be done out of UNSW and the Royal Hospital for Women. And so our first case. So this was a 30-year-old G2P1. She had had one miscarriage and one live birth. She had a occipito-posterior position during her attempt at her first labour, which was a brow presentation, which is very difficult for any obstetricians or anyone who can remember their obstetric terms. It's quite a large diameter and quite hard to deliver. She then proceeded to a caesarean after a prolonged second stage of trying to push, and then had quite a big PPH. She had an atonic uterus, and which caused bleeding, and she had a return to theatre for her ongoing bleeding and had a ureteric injury at the time of her hysterectomy. So at the time of her hysterectomy, she nearly died. She had 25 units of PAC cells, 30 units of cryo, 1 unit of platelets, and 11 units of fresh frozen plasma. So she drained the blood bank in her regional hospital where she was. The baby was born in good shape, but obviously she was very unwell for a number of days. But when she woke up in ICU, the first thing she said was, what's happened to my uterus? And she has a vague recollection of consenting to a hysterectomy, which she found the hardest thing of all. So then she contacted me, knowing that I was the CI on the study, and that was, her daughter has just turned 2, so 2 years after her hysterectomy. We enrolled her in the trial. She had 2 cycles of IVF through our FRC. She had 6 blastocysts cryo stored at the Royal. With the, just to clarify, with the original Swedish study done, in 2010, they were storing day 3 embryos. So they had 5 of those. They've got a lower success rate, obviously, than blastocysts. So we have 5 blastocysts as part of our ethics protocol, which have a higher rate of success. They're not tested because we don't have PGD testing for aneuploidy in our centre. So the donor was her mother, 53-year-old, who had had 2 normal deliveries, uncomplicated, who was otherwise a well and healthy woman. She was on no medications. We did note a subserosal, so a fibroid on the outside of her uterus, about 4 centimetres, which we didn't think was going to impact. They both, the donor, the recipient, and their respective partners had extensive psychological screening. And this is Kirsty and her mother on the day of surgery saying goodbye as the mother went in for her first surgery, which was performed on the 10th of January. And just to tell you about the surgery. So the donor had an epidural and a general. Well, the epidural was for post-operative pain relief. She had ureteric catheters placed because of the risk of ureteric injury, which is high, and that's what the Swedish team have moved towards after having a uretero-peritoneal fistulae. She had a vertical midline incision with the surgery as per the Swedish protocol. The total operating time for her was nearly 10 hours. She had DVT prophylaxis, which stayed for, she was on prophylactic Clexane for 6 weeks, and then had a imaging of her lower limbs before we stopped that because of her prolonged surgery. She was discharged with, or she was left theatre with a suprapubic catheter in place because of the extensive bladder dissection. And the uterus ischemic time was 4 hours and 10 minutes. So that's the time that the uterus is without its blood supply. And you try and do as much dissection in utero while you've still got the blood supply, and then you ultimately need to clamp in order to take the uterus off and then do the back table work. And then you put the uterus into ice, in an ice bath for cold ischemic time. And that 4 hours and 10 minutes was the combined cold and warm ischemic time. And cold ischemic time is a lot better than warm ischemic time in terms of damage to the organ. The recipient had a spinal and a GA. She had ureteric stents, which is not routine for a recipient, but because she had the ureteric injury with her first laparotomy for her atonic uterus and postpartum bleeding, she had a vertical midline incision. She had adhesions because of the postpartum hysterectomy and that 2 surgeries in the one day, and that took a bit of time to divide the bowel adhesions off the anterior side, anterior abdominal wall, as well as an adherent left ovary which needed to be dissected off, and she had a corpus luteum there which had to be divided off to prepare the blood vessels. So actually the ischemic time was a bit longer than we'd hoped because the preparation of the recipient took longer than we expected. We needed also to remove the tracheolectomy, so she had a subtotal hysterectomy, which is an easier hysterectomy to perform in the postpartum setting. You often leave the cervix inside you, but we needed to then remove that, and it makes it a little bit more tricky and takes a little longer. Her operative time was 6 hours and 12 minutes, which is at the upper end of what you'd expect, but it was because she needed those additional components, not just the recipient surgery. And then they were well post-operatively for the first day. So the donor was well and stayed in hospital for 8 days. However, she had no sensation to void, and then had some recurrent urinary tract infections, which occurred at 1.5 weeks, 3.5 weeks after the surgery, which both of them were treated, and she responded quite well to antibiotics. In the first instance, it was IV antibiotics, and we didn't get a positive culture. In the second instance, it was treated in the community, and we got a positive E. coli, and I think that it was all part of the one infection that probably wasn't treated adequately enough. At a week after that, so 4.5 weeks, she had her ureteric catheters removed, and the retrograde study showed that the ureters were patent. At 6 weeks, she did present again with the UTI, admitted, had IV antibiotics and orals to follow. She had a CT scan which showed no injuries, and she's had no ongoing injuries beyond that, apart from the fact that she hasn't got much sensation to void, which is a risk of this procedure, with particularly with radical hysterectomies, up to 10%, where the nerves have been impacted by the surgery of the bladder, and she just has to make sure she goes to the bathroom at certain times of the day. And with time, it can take up to 12 months to recover. The recipient, day 2, developed some tachycardia, drop in her HB, and we confirmed a hemoperitoneum. She had post-operative bleeding that required 5 units of packed cells. This settled with just the transfusion. She was bleeding probably through the corpus luteum, unfortunately, and she has now since been seen by Giselle Kitson-Gerber because of her postpartum hemorrhage and then the subsequent hemorrhage. She did bleed a lot intraoperatively, more than you'd expect. And she's had initial investigations for von Willebrand's, etc., and everything's come back negative, and she's having some additional hematological investigations in case she does have a bleeding propensity. However, did do very well after that conservative management. She transitioned her immunosuppression, which was, rather than thioglobulin, it was basiliximab and mycophenolate mofetil, which she was on for 6 weeks, and then she ceased this and needed a 6-week washout. So we transitioned from MMF to azathioprine, which is a safer immunosuppression for pregnancy. She needs a 6-week washout after the MMF, and she was on azathioprine and prednisolone. And she had her first period 5 weeks after surgery, another period a month later. And pleased to announce, we did an embryo transfer for her after her washout, so 12 weeks after her first surgery, and she is actually pregnant, which is very exciting. She has had some early bleeding, but she's literally about 4.5 weeks pregnant, so everyone's very excited about that, most of all Kirsty herself. So the planning and beyond, obviously we needed to wait for the washout period. She needs ongoing cervix biopsies, so we were doing those weekly initially down to fortnightly and monthly, and then now she's just had one final one until she now goes into trimesters. So she'll have one now, which was performed in her regional setting and is getting transported to COFs, and none of her biopsies have shown any evidence of any rejection. She'll have one in trimester 1, one in trimester 2, and another one in trimester 3, because actually when you are pregnant, your chance of rejection is actually lower because it's a relatively immunosuppressed state in pregnancy, and you can often wind back the immunosuppression in pregnancy, and they see that a lot with kidney transplants. She will either have a hysterectomy after 1 or 2 children, and she's really not sure whether she'll have 1 or 2 more. The donor I mentioned earlier needs ongoing bladder care, no more UTIs, is much better with her voiding, but hasn't got a great sensation to void until her bladder becomes quite full. So we're just doing bladder training to make sure she goes to the bathroom and doesn't over-distend her bladder. And obviously ongoing psychological support, because it has been a bit bumpy. I think it's difficult for any woman having a hysterectomy, and you do see a little bit of a dip psychologically in women who have a hysterectomy. That's quite well documented, but I think then it's also difficult in the donor recipient setting, and it's quite common for donors to feel to have a bit of a flat period, even for kidneys and other donations that they make, probably because they have to go through surgical, recovery, etc. Our second case, so she was performed on March 10. She had MRKH. She always wanted to be a mum. She had attempted surrogacy many times, twice actually, without success. Her mother was not a match in blood group, and blood group is the first match that you do, and then beyond that's HLA matching. But her godmother was tested and matched in blood group and HLA. She has 6 tested embryos which were stored in an external IVF setting, and she already had those prior to joining the study because she had intended to do surrogacy again. For her, the donor surgery was much quicker, 8 hours, and the recipient surgery was 4 hours. It was much less complicated because she didn't have, although she had had laparotomies before as a child for reflux, and she had had a hiatus hernia repaired, so she had upper abdominal surgery and some adhesions. The pelvis was relatively untouched. So the donor has had a couple of UTIs and has actually now had some incontinence, which we're investigating. The recipient's done very well, and the main issue with this pair is that the donor is CMV positive and the recipient CMV negative, and that's an issue for transplants in general, where you may then have a CMV infection as a result of your transplantation and can become quite unwell with CMV. And the other issue with CMV in pregnancy is not fantastic, particularly in the first trimester, and is the most common cause actually for an acquired infectious cause for developmental delay in babies. So to get CMV in the first trimester is something really of concern. So we do tend to wait a bit longer and make sure she doesn't have a CMV infection. So this is a community of the international uterine transplant from around the world, and we have a conference every year. This was Cleveland in 2019, just before the COVID shutdown. I was very happy to go to, and there is now a textbook in this space. So any questions in my 5 minutes?
I might hold off on questions.
Yes. Actually. No, absolutely.
One of the things I was just going to say is, so the first time I heard about this, and I don't know if anyone else listens to the podcast, The Quickie. Does anyone listen to The Quickie? So have a listen to The Quickie. So your first recipient and donor, there is a patient story. Oh. So certainly from the recipient's side of the story about what she went through, getting in contact with you, yes, and then talking about her experiences, asking her mum to be part of that journey with her, and I think it's absolutely fascinating. So yes. Completely separate to having you present today, I happened to listen to that. It was only released in March. And for those that are interested, it is called Aussie First, How a Mother Gifted Her Daughter Her Uterus. So thank you very much. It was fantastic. And I'm sure if anyone's got any questions that feel free to get in contact with you. Is that okay?
Yes, absolutely. I'm on, my best email is unsw1, r.deans, unsw.
Excellent. Can we just say a quick thank you?
And I do have to run. Apologies. I've just pulled that out. Is that okay?
I hope so. Support. We'll get some. All good. So our second speaker today is Associate Professor Antoinette Anazodo. Oncofertility presentation, a novel agent and gonadotoxicity. She's a paediatric oncologist with the Kids Cancer Centre and also a director for the adolescent and young adult adolescent care with Sydney Children's Hospital in Prince of Wales, and also a conjoint associate professor with UNSW. And we look forward to, excited about your presentation too. Thank you very much.
Okay, so it's a bit hard to do a presentation after that because that's just so fabulous. And what I was going to say before Beck left is Beck got the Australian Woman, New South Wales Australian Woman of the Year, and that was a well-deserved for all the work that it's really taken. So you have to congratulate her. So I'm going to talk about one of my research studies, and I was asked by Toby to do an interim analysis so that I can present here. So I'm going to talk about year 2 data. Let's start. So the work I'm going to present is about the gonadotoxicity of novel agents. And most of the people in the room will know about the gonadotoxicity of our standard chemotherapy and radiotherapy. And for 1 in 10 cancer patients, they'll have some either sub or infertility as a result of either individual combination treatment. We know that the effects of these has an impact on these families at 1 year, 3 years and 5 years. It's the area of greatest need outside ongoing cure. And so ongoingly, these patients have both medical and psychological needs in this instance. So one of the reasons I got involved is that, cancer survival is improving. And when you have improved cancer survival, especially when you have patients of a reproductive age, we often are asked about the risks of infertility. And so there is growing data on standard treatment, but very little, as I'm going to present, on the new novel cytotoxic and immunotherapy treatment. And that has an impact on the recommendations that we make. So what are the non-cytotoxic and immunotherapy drugs? So these drugs work in a different way to standard chemotherapy. So they are drugs that have different names. So we often call them precision medicine or targeted agents, and they're drugs that are tailored to specific molecular pathways. There are a number of different groups of these drugs, and they work in different ways. So it may be inducing apoptosis, in cell signaling, the immune system, angiogenesis. 2001, the first novel agent was imatinib, which we use for most commonly for treatment of CML, so a hematological cancer. And you'll see over that 20-year period, we now have 94 approvals of these new novel agents. And every year there are more and more that come through. There's about 10 cancers that are solely treated with these novel agents. So the one that everyone knows about is melanoma. And you'll see, 10 years ago, melanoma stage 3 and 4 were incurable or had very low cure rates. And now the cure rate's over 50%. So these drugs have made a significant impact for some very rare cancers. But more and more they're being combined with standard treatment for both relapsed, refractory, and some rare cancers. So they are increasingly a very important part of cancer care. So why did I become interested in them? Well, we know that there's very little data for the reproductive effects of these drugs. And the first study I was involved in was in 2017, where we were just auditing the protocols that we had in clinical trials across our campus, just to look at whether they had anything about the reproductive effects of these drugs. And surprisingly, it was actually more than we thought. 32% of the clinical trials that were a combination of national and international protocols had some information. And then we looked further and did another study that was published. An ILP student did this. And so we were looking at the approval. So for a 5-year period, there were 32 drugs approved. And we wanted to look at the specific animal and human data. And so none of the 32 drugs approved had any human data, but you'll see 23 of the 32 drugs had preclinical animal data. Of those, 9 had inconclusive data on fertility outcomes, 9 had data on male, 3 had data on female infertility, which certainly is a concern, and only 2 reported no adverse experimental effects. So here we've got some early information suggesting that fertility or infertility may be a problem in these new drugs. And that's important because when we think about gonadotoxicity, we usually, our standard way clinically is to put them into 3 groups. Low risk, which is less than 20%, intermediate risk is 20 to 80%, and the high risk, which is more than 80%. So here we've got a class of drugs where there's no data from a human perspective, and then there's animal data that is suggestive. So, we then as clinicians have to think, what are our recommendations for fertility preservation and reproductive survivorship care? So we started looking at the published data on pregnancy, and most of this is in case reports. So for the tyrosine kinase inhibitors, and there's a number of different groups, you can see that there is data on pregnancies, but when you have case reports or small case series, you don't get a good idea of the incidence and impact. So we still don't really know when you're talking through the group of patients just on TKIs, what's the chance of these patients having pregnancies. So then we looked at what data is available for the gonadotoxic risk. So can we utilize that data to make some recommendations? And again, these are mostly case reports, mostly TKIs, but a few other studies. So there's one study on post-mortem testes where they looked at spermatogenesis of patients who had melanoma. There's obviously problems with that because these males who died were very sick, and that has an impact on the histology. There's one larger case series, there's 25 men on checkpoint inhibitors, and then there's one very nice New England Journal review looking at a gamma secretase inhibitors. Again, this data is mixed, some saying that there's some impact on male and female fertility and some saying there isn't. So, as I said, overall there's an unmet need, making it very difficult for us to make a recommendation about what fertility preservation should be in these patients. So my study was to determine the impact of novel agents on fertility in male and females and to initiate follow-up so we could give some recommendations over time as to whether the infertility was short-term during the treatment or persistent. And that's really important because the main difference between these drugs and conventional chemotherapy, radiotherapy is for those patients who have a good response to these novel agents, they often continue to have them indefinitely. And so they become a group of patients that, in time we'll look at as chronic cancer patients. Like a diabetic, they'll be taking their oral tablet or short infusion for a long period of time. And as of 2023, there's very little information about how long patients should be on these novel agents. So I have a large cohort of patients taking these drugs over the last 8-year period. Okay, so the study has two cohorts. And cohort 1 is longitudinal data of both males and females, and it's looking at patients' reproductive function prior to starting cancer treatment and then following up at 12 months. But because this is such a rare group, we also have a cross-sectional group of patients who have just had novel agents and are followed up at one time point. We are only recruiting patients who have been treated with a novel agent. So all of those who have chemotherapy excluded from this study. And if you have radiotherapy, which will affect reproductive function, so any CNS radiotherapy, TBI, or anything to the pelvis or genitalia, you're excluded. And so there's about 10 cancers where patients could be referred. So we knew that the recruitment to this study is going to be slow, and at the moment it's only open in 3 studies to give us some pilot data, and with the hope that once we get this pilot data we can then apply for a grant to have it in multiple institutions. So the study is open for males aged 18 to 65 and females 18 to 45. We did want it to be open for pediatrics, but the ethics group said that because fertility preservation in children that have undefined infertility is not standard of care, they wanted us to just do the data for adults first, and then in a subsequent revision, depending on the data, include the children. It's open for cancer patients, but it's also open for non-cancer patients taking novel agents. And you'll see that that group of patients is actually growing. So the biggest group at the moment has been the MS group, but there's a number of other agents being used for neurological and immunological reasons. And obviously, patients have to consent and agree to participate in the assessment. So for the female patients, we're looking at a reproductive and general medical history, taking reproductive hormones. For cohort 1, it's going to be at before the cancer treatment starts and at 12 months, an ultrasound scan before cancer treatment starts and at 12 months, DNA blood test to identify susceptibility genes in a separate study, and a questionnaire about their reproductive status. For male patients, again, the reproductive and general medical history and examination of testicular volume done with an orchidometer, and some centres decided rather than doing that, an ultrasound of the testes, a blood test looking at reproductive hormones, a semen analysis and sperm banking. So The pilot data we have so far. So over the last 2 years, we've had 34 male patients, 19 in cohort 1 and 15 in cohort 2. The mean age is 32.4 years with a BMI of 27. And we did collect some data on some of these other things like smoking, drinking, BMIs, because if you look at the non-cancer fertility data, they often look at those as covariables, and we wanted to make sure that if we found any changes, it wasn't because of a covariable. Okay, the biggest underlying disease is melanoma or hematological disease, and then we had a number of other cancers. We had patients with both antibody treatment and small molecule enzymes, and there are 6 therapeutic classes and a number of different agents. And the biggest problem we're going to have is that to answer this question, we're going to need a lot of data for each of the classes. So this is really pilot data to first see, is there an effect? And then if we see an effect, to then hone in on which drugs we think are at all involved. So 10 of the 34 males had previous children, none had prior infertility, most were non-smokers, and most reported light alcohol consumption. So the most important thing that we saw, and I'm going to show you the table, is that sperm output and concentration was significantly lower on treatment compared with pre-treatment. For sperm outcome, none of the covariables was significant. There was one male patient who had melanoma that had normal sperm output prior to starting treatment and was azoospermic at 12 months, but had no other, importantly, gonadotoxin exposure. The semen volume, sperm motility and morphology were not significantly different. So the non-cytotoxic treatment was associated with an increased serum FSH when you compared the results between cohort 1 and 2 and pre and post. The treatment was also associated with decreased serum inhibin, and there was no difference in testosterone LH when you looked at the treatments. So here's the things that were different, and sperm density, total sperm output. These were all you can see in bold, the serum FSH and the inhibin, and I've compared the pre-treatment to the post-treatment. Now for the female, we don't have as many patients yet. We certainly, all of these patients in cohort 1, certainly harder to recruit because undertaking IVF when you don't know whether there's going to be an impact on fertility is a harder ask. This group of women had a mean age of 31, again, a mixture of cancer types. So here we had 6 therapeutic classes of drugs. These were all small molecule. 6 of them were small molecules and 1 antibody treatment. So 6 of the 7 women continued to have regular menstruation. So far in the results, we have shown evidence of ovarian toxicity with a reduction in antral follicle count and a reduction in serum AMH when you compare the results, but we have an inconsistent pattern of serum LH, FSH and estradiol. So I guess at the end of the 2 years, we still have a small cohort of patients so far, and we're looking to other centres who treat these novel group of patients to increase the sample size. So far, we have seen a reduction in sperm output by about 50%. We've seen evidence that we're getting an elevated serum FSH and undetectable inhibin B, and that's consistent with spermatogenic damage without another cause shown. I think these the early data we've got for the males is certainly warranting us collecting more information. Again, in the females, we've got some early evidence of ovarian toxicity, but it's very small patients. Our main limitation is our sample size. It's going to take a long time to continue to get this data unless we have large grant funding, because these patients are small numbers across many cancer centres. And it's really too early to make comprehensive recommendations. But I would say that, more and more the guidelines for fertility preservation are pointing to the fact that these patients should at least be referred for a conversation with a fertility provider. So I think that was my last slide, and happy to take any questions.
Thank you. Yeah, need the microphones. Yeah, I think we both can all agree we had two absolutely fantastic presentations, and certainly a lot of information, and certainly no lesser than the person in front of you. And yeah, it was very, very well received. And I know we do have a question from the audience. Oh, a couple of questions.
What stuff? You've got a vast different array of drugs that you're looking at, and obviously they're all going to be working under different mechanisms, affecting different pathways. So it's going to be tough, to determine which of those are toxic when you're going to have very low observations in any particular drug, because some drugs are going to be affecting things in different ways, activating different pathways and affecting different things.
I agree. I mean, the thing is, we were doing that systematic review of the data to see, is there any evidence to point out both animal and human toxicity, and not very much has been published. But certainly within each of our caseloads, we know of patients who are having problems. So what I thought is we'd start with the pilot data, and then we did a calculation, and that we needed about 25 patients in each group to show a difference. Now, when you're seeing how many new classes of drugs there are, that's actually a really big study. And so, I think it's going to need lots of collaboration to get that answer.
When these drugs are approved by the regulatory body, say, for example, the FDA or the TGA, they would normally have to undergo a reproductive toxicology test. So are you not able to get hold of that information?
Yeah, so there is proprietary data collection, but they don't have to do long-term reproductive data. That was one of the slides I took out because I thought there'd be more questions for Bex. So that's where actually there's limited data. All of them have animal data. And like I said, of that 32, you could see, 23 of them have got some animal toxicity. But long-term human data has not been collected. And thinking through, 2020, so in 2020, that's 20 years of the use of some of these agents. So the tyrosine kinase inhibitors, we're beginning now to see those case reports because those patients are trying to have pregnancies. But I guess we need more than case reports to answer the question.
Okay, and we'll just take one final.
A quick question. Antoinette, fantastic study and so important to clinical practice. I just want to, you are collecting AMH on the males, and I wondered why. Are you collecting FSH and LH as well?
So I'm doing a study with David Handelsman, and in some of the earlier male work, they did look at AMH. So he was interested in seeing whether, as a biomarker, it would be useful. So I'm going to be doing the females, he's doing the male stuff.
Thank you very much. Let's get a final clap for everybody. Well, that's it. We'll end our session. Thank you very much for those that have attended it here in person and those online, and hopefully we'll see you next month at our next session. Thank you.